Good morning, good afternoon, good evening, everybody. Thanks all for registering and attending the ISHLT Pathology Professional Community webinar. My name is Fiorella Calabrese. I'm a full professor at the University of Padua in Italy, working there as a dedicated lung pathologist. And I am a long-time member of the ISHLT, covering several positions. Currently, I am the pathology representative at the Advanced Lung Fellow and Transplantation Interdisciplinary Network Steering Committee. So before starting this very interesting webinar, let me give you all a little information about the ISHLT structure. There are 10 professional communities that represent a place of different kinds of specialists that focus on different care of our patients. And each professional communities is represented on the 4 interdisciplinary network steering committee: Advanced Heart Failure and Transplantation, Advanced Lung Failure and Transplantation, Mechanical Circulatory Support, and Pulmonary Vascular Disease. We are very grateful to ISHLT and all members, allowing us to offer free and open professional community webinar to anyone who is interested in what we do. Please to consider becoming a member of this important international interdisciplinary society if you are not yet. So back to our webinar. The webinar is entitled Prime Time or Overtime, Lung Transplant in Elderly. A really great topic that will be presented following the clinical-pathological conference format. So a young early career specialist will present an intriguing case, and then 2 expert specialists will discuss from a clinical and a pathological point of view lights and shadows of lung transplantation in elderly recipients. I'll co-chair this webinar with Dr. Gregor Vlacic. He is a dedicated lung pathologist too. He is working in Golnik, Slovenia. I know Gregor very well, as several years ago he was one of my most enthusiastic and brilliant fellow for lung transplant pathology. And I'm delighted, at the same time excited, to co-chair this webinar with him. So now I'll hand over to Gregor to provide you all a little information about webinar, and moreover to introduce the first speaker. Please, Gregor.
Hello, everybody. Thank you, Fiorella, for the kind introduction. Yes, welcome to the webinar. Just some information about the house rules, let's say. So please just remind to be on mute the whole time during the presentations. And if you have any questions, please submit them in the chat box. And then we'll have at the end of the webinar a Q&A session where we'll try to go through as many questions as possible. So now, without further ado, I'd like to present the first speaker, Dr. Grace Ream. She's a 3rd-year pulmonary and critical care fellow at the Duke University. She has clinical and research interest in lung transplantation, and more specifically, understanding the clinical and genetic risk factors for development of CLAD. Please.
Hi, everyone. Thank you so much for the introduction. So starting off with our case presentation here, we have a 73-year-old gentleman with a history of RA-ILD who was referred to Duke for consideration of lung transplantation. In addition to his more advanced age, he had significant comorbidities, including coronary artery disease. His most recent stent was placed about a year prior to his eventual transplantation. And then additionally, he had heart failure with mid-range EF, CKD3A, and then a history of factor V Leiden deficiency with a prior VTE on warfarin. His pre-op history kind of is notable for Enbrel. He was managed with a TNF inhibitor for his rheumatoid arthritis, and that really controlled his extrapulmonary disease very well. And then he additionally was on OFEV for his progressive fibrotic lung disease related to his rheumatoid arthritis. And then 2 years prior to his evaluation, he was started on oxygen therapy, and then on evaluation was using up to 4 to 6 liters with exertion. And then his eventual donor and recipient characteristics for CMV and EVV are noted here. And then I have some representative slides from his explant pathology that I'm going to hand over the mic to Dr. Pivlisco to help walk through.
Thanks, Grace. I did want to start with what we received in the gross pathology specimen. So we received a left lung. This is a single lung transplant. And the pathologist assistant or resident who grossed the case described that within the upper lobe, there was some moderate subpleural fibrosis, predominantly inferiorly and laterally, with some central sparing, and that there was honeycomb change noted within the lower lobe. I mainly wanted to include this because I know that there are some consideration is being given to how we more formally approach these specimens, native lungs and native hearts by the ISHLT. And so here in the block summary down at the very bottom left of your screen, you can see that we typically take a bronchial margin, vascular margin, and some representative hilar lymph nodes. And then our standard sections, if everything is sort of looking generally the same, would be central and peripheral sections from the upper and lower lobes of lung. This is a low power image showing the explant, and what you see on the left-hand side of your screen is out towards the periphery. So we have the pleura out towards the far left. Coming in, there's some prominent areas of fibrosis. This is where the honeycomb change was dominantly. And then as we move inward, closer to some bronchovascular bundles, you can see that there is a little bit of mixed interstitial inflammation. At higher magnification, there are areas where we have some prominent fibroblast foci scattered, admixed with some chronic inflammatory cells. All of these in areas of dense fibrosis. At the leading edge, you see the fibroblast foci, and then extending in towards areas of more normal lung towards the right-hand side of your screen, we see that inflammatory infiltrate does persist a bit. Again, this just showing that this is a variegated pattern of fibrosis. And then lastly, we do have some areas of airway-centered remodeling. So here, on both the left and right, we have small airways with a fair amount of peribronchial metaplasia. Again, some robust chronic inflammation, fibroblast foci. So overall, a temporally and spatially variegated fibrosing process. And knowing this patient's underlying history of rheumatoid disease, this would fit with rheumatoid lung.
Great, thank you so much. So briefly touching on his immunosuppression regimen, this patient received our standard kind of induction protocol at Duke with basiliximab and high-dose steroids, and then his 3-drug maintenance regimen is below. We had reduced his tacrolimus goal just given his history of pre-existing CKD and his more advanced age. And so moving on to his overall transplant timeline, he underwent an uncomplicated left SHLT on Christmas Day, which I thought was a really great Christmas present for this patient. Really uncomplicated initial course. He returned to the ICU without any pressors. He was extubated the next day. He was past his fees, eating and walking by post-op day 4. And then post-op day 9, he had his first post-transplant airway exam. And really kind of benign findings. He had some minimal airway edema, minimal secretions, and overall his anastomosis looked well healing. Notably on day 12, this patient had an echocardiogram that was done for workup of worsening hypotension and renal failure. And he was found to have a large pericardial effusion and went to the OR for a pericardial window. They evacuated almost a liter of serosanguinous fluid. There was also some concurrent concern for constrictive pericarditis, and on pathology, his pericardial samples ended up having organizing fibrinous pericarditis, as well as some mild pericardial fibrosis. But, after his OR visit, he did pretty well, and he was discharged by post-op day 21 from the hospital. I wanted to briefly touch on constrictive pericarditis as a rare complication following lung transplantation. It's caused by the scarring and eventual loss of elasticity of the pericardial sac. It's usually chronic, but can be subacute, and there's case reports as early as 4 months following transplantation. And, notably, constrictive pericarditis is somewhat difficult to diagnose, and it shares a lot of hemodynamic similarities with tamponade physiology. But kind of the hallmark characteristics on invasive cardiac hemodynamic monitoring is the elevation of diastolic pressures that become equal between the RV and LV, and this concept of interventricular dependence. With inspiration and increased venous return to the right side of the heart, you get increased right-sided pressures, but that happens at a cost of decreasing the left ventricular pressures. And so at Duke several years ago, we looked at the incidence of constrictive pericarditis after lung transplantation. We included just over 1,200 lung transplant recipients at our center and found 10 patients, or 0.8%, that went on to develop constrictive pericarditis at a median time of 11.2 months. And this was similar to the previously described incidence of around 0.4 post-transplant. So going back to our patient, he unfortunately suffered from recurrent episodes of acute rejection post-transplant. Here I have his lung function plotted over time, and each arrow corresponds to the subsequent bronchoscopies that I'll briefly talk about. At our institution, we do perform routine surveillance bronchoscopies following transplant, and we are pretty aggressive about treating even minimal A1 rejection in the absence of clinical signs or PFT declines. And so his first post-transplant bronch had A1 rejection that was treated with steroids. Again, was persistent on a second bronch that was treated with steroids. At that time, he eventually went on to grow MAC in his BAL cultures. And then, unfortunately, the third bronch, he again had recurrent A1 with MAC. He was started on MAC-directed therapy, and the plan was to admit him for RAT-G after 2 weeks of treatment of his MAC. And then these are the 3 points that we just looked at. Around here is when he got his RAT-G therapy, and unfortunately, the subsequent bronch still showed A1 with MAC still present. As all this was going on in the background, he unfortunately had a growing right lower lobe mass that further complicated kind of all of these recurrent rejections. This is his pre-transplant CT, and I'd like for you all to focus kind of around this area in the posterior right lower lobe. I think in retrospect, we can see something here, but, pre-transplant didn't raise any flags just in the background of his surrounding ILD. As we progress after his transplant and focus in on this area, we see that it definitely is becoming more conspicuous and enlarging over time. And so unfortunately, a PET CT demonstrated that this area was PET avid. Luckily, he did not have any signs of metastatic disease. And so if we move on to kind of his further course, here is when he underwent a right lower lobe wedge resection about exactly a year after his transplantation. And then on pathology, he was confirmed to have squamous cell carcinoma. And so, lucky for him, he did have complete resection. This was stage 1A, and so he didn't require further treatment. But then at his first post, wedge resection office visit, his lung function, took quite a bit of a nosedive. Transplant bronch that was performed at that point, unfortunately, did demonstrate A2 rejection, persistent MAC. He was just treated with steroids in light of his, recent cancer. And then I'll pass the mic back over to Dr. Filisko to talk about some of his surveillance bronchoscopies and the squamous cell carcinoma.
So I have a couple of representative images of what were called grade A1 lesions. So we can see here in the very center, a nice tight cuff of perivascular inflammation. So this was biopsy number 1. Moving on to biopsy number 2, we again see fairly unremarkable surrounding alveolated tissue. And at the very bottom towards 6 o'clock, we have a vessel passing through from left to right with a cuff of perivascular lymphocytic inflammation. And then lastly, we have a somewhat smaller cuff that's still present. In light of the patient's history of coexisting MAC, there was no evidence of infection in the surrounding lung tissue. That being said, sometimes we do see perivascular lymphocytic inflammation in the setting of a mycobacterial infection. And then lastly, this patient did have a resection of the right lower lobe nodule. Gross examination demonstrated a 2.2 centimeter mass with clear margins. And microscopically, when we go to look at this lesion, we see that intermixed in all of the fibrosis that we know is part of his native lung disease, we have abnormal cells that are of squamous histology, and he was of low stage. So we can see here more atypia. I will admit it was at low power a little hard to know, okay, have we gotten into the tumor and now are we out of the tumor? But on closer examination, the areas of atypia were relatively clear. So we have a low stage 2 centimeter squamous cell carcinoma of lung with negative lymph nodes.
Thank you. And so, this is the full trajectory of the patient's PFT's post-transplant until his most recent follow-up with us. We have a lot more time points here, so all of the points got smushed together, making kind of all the peaks and valleys look a little bit more dramatic than my last slides. But here around is where he underwent his resection for his lung cancer. This is the A2 rejection. And so, he clearly took a significant nosedive in light of those two events, and he never really fully recovered. But, despite all these complications after his transplantation, the patient is still alive. He just had his 3-year anniversary back this past Christmas. And from reading his notes, it still sounds like his quality of life is pretty good. He is not using any oxygen. He's still pretty active, living in warmer climates with his wife and coming up to see us a few times a year. And so I think this is a really good case that highlights some of the potential complications following lung transplantation or more elderly patients. But it also highlights, that these patients still have the potential to be resilient despite these complications. And so I'm going to hand it over to Dr. Pavlisco and Dr. Spurry to talk a little bit more about our discussion points and the lights and shadows of transplantation. I did want to thank everyone for your time, and I'm sorry I have to log off a little early to catch a flight, but I'll try to look at the chat as I travel to answer any questions. Thank you.
Thank you, Grace, for your great presentation. So now I think it's the time of our expert specialist, Dr. Lorenzo Zaffiri. He will discuss the topic elderly recipients, lights and shadows for the clinician. Dr. Lorenzo Zaffiri currently is the Assistant Medical Program Director of Lung Transplant at Cedars-Sinai. Is a clinical and translational research focused on the mechanism of host immune responses to viral infection, in particular Epstein-Barr virus and the cytomegalovirus in lung transplant recipient. He is a long-time member of the ISHLT, currently covering this position of a pulmonology professional community representative to the Early Career and Training Committee. So we are very interested in listening to him. Please, Lorenzo.
Thank you, Professor Isabel Brizes. Thank you, Dr. Vlasic, and to ISHLT for the invitation to talk during this webinar. We're gonna try to touch base on this topics, looking at what are the characteristics, what are the challenges of transplanting elderly individuals, what are the lights and the shadows of what we are facing in these early stages of increasing the age of our recipients. Despite an upper limit of age for lung transplant has not been yet established, age must consider in the context of medical comorbidities, performance status, and expected outcomes. In the United States, the portion of lung transplant recipients over the age of 65 has grown over 400% in the last 15 years, and they now account for over 30% of all lung transplant recipients. There are at least 2 primary reasons that I can think of for this increasing age in lung transplant recipients. First is the change in lung diseases. Transplants for cystic fibrosis and pulmonary hypertension have decreased due to effective therapeutic regimen for these advanced lung diseases. However, pulmonary fibrosis, which is currently the main cause of transplantation, is significantly more common for a patient that are older than 60 years old. And this has led many programs in the United States to liberalize their listing criteria, such as older age is not considered anymore an absolute contraindication, but a relative contraindication. This has been a road that we've been, again, riding for the last 15 years, and we arrived to this point. This is one of the first studies that look at the survival of candidates older than 65 years old, and also try to determine whether the type of transplantation, single versus bilateral, would bring any benefits. Is a retrospective analysis of a large data registry called SRTR, and they include over 10,000 lung transplant recipients between 2005 and 2012. The vast majority of the patients were in the first age group, 12 to 64, about 80% of them. And the rest of the patients were in the 65 to 69, 70 to 74, and 75 to 79, representing the last two, about 5% of all the patients. When we look at their characteristic, you can see that gender changes with increasing age. More male were transplanted in the last two group, and also a restrictive lung disease as primary cause of transplantation also went from 48 to 86%. Inversely, we can see that more patients receive a single lung transplant procedure with increasing age. And importantly, we see a decline in the requirement for ventilator and mean pulmonary hypertension with increased mean pulmonary artery pressures at the time of transplant, suggesting that there was a very thorough selection of these older candidates. In the table here, we can see their short and long-term survival among those age group, and we don't see any big difference in either bilateral in the single. However, we see a significant decline in their survival already at 30 and 90 days for older patients that received a bilateral lung transplantation. And therefore, a lot of programs have now kind of changed on the light of this data, suggesting to a single for older patients. In the Kaplan-Meier, in the single lung transplant recipients, we don't see a big difference. A little bit more evident in the bilateral, but with the evidence that younger patients have survival benefits compared to the older one. More recent data, we actually move a decade between 2012 to 2021. This is a single center retrospective analysis of 800 lung transplant recipients at Temple, was presented last year during the last meeting, international meeting. They divided the group with the age of 70. So they already also moved the age to 70 years old from 65. And they look at their survival, comparing single lung transplant versus bilateral lung transplant, and they did not see any difference in their survival of this patient, suggesting that we're getting better. We are doing more transplant. We're doing definitely better survival for age of 70 in each type of transplantation. However, transplant survival is not the only important measure that we can study. Lung transplant has an important impact on quality of life. And in fact, international guidelines suggest that quality of life improvements should be used along with survival to assess the effectiveness of transplantation. This is a prospective cohort study from the Toronto group that look at patients with advanced lung disease enrolled at the time of listing or the time of their consultation for lung transplantation. 326 patients underwent the lung transplant, and they were asked to complete at least 5 different measures of health-related quality of life questionnaires, including the St. George, the 36 items short form, and of those, at least one of those measures were completed. The characteristic of the patients, again, vast majority of patients were in the 50 to 60 years old category, and about 13% of the patients, 15% of the patients were 65 and older. Most of them were male. The vast majority received a single lung transplant. When we look at those short health-related quality of life measure, you can see before transplant, which is represented by the red dotted line, there was a steady decline in the health-related quality of life. They rapidly changed after transplantation. There was an improvement in, especially in the first 3 months, followed by a more steady cruising and some decline. However, the decline was not age, especially the 70 to 75, did not have much difference in the health quality response. Using those 5 different instruments, they were also able to develop a predicted model to see if patients were able to stay after transplantation in a better state of health, same, or death. And I'm just looking at highlighting these last 2 groups, 50 and 60 plus. And you can see in the 60 plus, after the first year, the majority of patients were able to stay in a better state of health, and then they were crossing around 4 years for survival and increasing in death in these patients. So they concluded that lung transplantation confers a large benefit in quality of life that is not influenced by the patient age. So suggesting again that the quality of life is definitely something that we should look for these patients. However, in the shadows, we had to talk about their survival. This is a large retrospective cohort study that was conducted by the Duke group. They were, again, looking at the SRTR data registry. The aim of the study was looking at specifically survival of lung transplant recipients 65 years and older, the clinical factor associated with that, and there was any clinical difference leading to worse outcomes. They were able to obtain over 5,000 lung transplant recipients data. In this age group, 69% were male, almost 90% white, 55% receive a single lung transplant for restricted disease. And what they found that the median survival, it was about 4.4 years, which is a little less than what we expect for our average survival at this point. The Kaplan-Meier survivals were 83% at 1 year, 62% at 3 years, and 45% at 5 years. When they looked specifically at the impact of age, they saw the subject in the age group 70 to 74 and older than 75 had an increased mortality risk at any time after transplant compared to the patient that were 65 to 69. Again, suggesting that they can survive, but there are definitely a lot of risk associated with their survival after transplant. They went on looking at the data available in the registry and tried to understand in a multivariable analysis what are the clinical characteristics associated with worse survival. And these are the 8 characteristics that were independently associated with worse survival: age, creatinine and bilirubin level at the time of transplant, use of steroids before transplant, single lung after the first year, diabetes from the donor, CMV mismatch. The last 2 is the 8th is hospitalization, and then a special mention for ECMO. Those last 2 are unfortunately the ones that are associated with the worst survival in this category of patients. Hospitalization, in particular for patients that are over the age of 75, is increased risk of mortality over 400 times. And similarly, when they look at ECMO, there was a very small subset of patients, but they saw that there was an increased risk of mortality for patients that were bridged to transplant for ECMO in older state, suggesting again that there is, this is a retrospective analysis, but taking their conclusion with caution, but suggesting the selection again should be very, very thorough. What a retrospective analysis cannot give us is an analysis of what are the modifiable characteristics of our patient. Given the scarcity of organs, we need to really work on identifying and potentially modifying the characteristics that are associated with poor outcome. Age is not modifiable. However, when we do those eyeball tests for patients, we should probably start thinking a little bit more the difference between chronological age and biological age. Biological age refers as the underlying and disease-independent accumulation of changes, pathophysiological changes that contribute to death. And with the idea of biological health, we need to talk about frailty, which is a concept that we imported from geriatrics and is very hot right now in organ transplantation. Again, kind of the same concept is this multiple system changes that increase the risk of poor outcome, falls, disability, hospitalization. What we have learned so far in transplantation that is not age-related is often, it happens in any disease, but is highly associated with poor outcomes. There are two different main models to define frailty. One is called phenotypic model that looks at they assess the vulnerability, unintentional weight loss, reduced strength, reduced gait stability, and a more complex that is called cumulative deficits model that puts together multiple variables from different aspects, nutritional, cognitive, and also medical. A little bit more difficult to assess in the clinical settings versus the phenotypic is fairly easy with a short physical performance battery. But given the difficulty and the challenges in defining frailty, there is a strong consensus to put together experts and try to have a better definition on specific lung transplant frailty. And there are papers coming from Toronto and San Francisco that are very good, suggesting that we should probably just look at our disease, our organs, and our recipients and develop a multidisciplinary approach looking at aging, immunity, nutrition, and muscular strength to put together what is an assessment of frailty. And finally, I'm gonna try to switch gears and talk about age and telomere in lung transplantation. We know that telomere are those low repeated nucleotide sequence, those caps at the end of the chromosome to prevent degradation. We know that malfunction of the telomere functionalities and gene repairing is associated with development of pulmonary fibrosis as well as the impact of T cells. There are a couple of papers I want to mention. The first one from the UPMC group that look at the evaluation of telomere length and the quality of circulating T cells and the burden of acute cellular rejection in patients after lung transplant. They identified 106 patients, and 57 of that have lymphocyte short telomere and underwent lung transplant. And when they look at their circulating T cells, they look at all the different phenotypes. Pre-transplantation in red is normal, and in blue is the short telomere population. They didn't see any difference in the most common known phenotypic, the CD8 circulating. However, after transplant, they saw a premature aging of these cells. In fact, there was a rapid increase in the terminally effector CD8 expressing the CDRA instead of the naive cells. And those cells started to express the markers of immunosenescence like CCR5 and CD57 especially. And when they look at the ACR burden, so acute cellular rejection burden, they saw a significant decline, again in blue, in the burden of rejection with increasing age in the short telomere population, but that was not confirmed in the patient that did not have short telomere. So in the group, they still have the same amount of acute cellular rejection. And then the last paper from John Greenland and the group is UCSF, looking at the airway telomere. They published before the short telomere in the tissue of explant with patient with CLAD, and they also found that influenza in an animal model can cause telomere dysfunction in the lung epithelium. So they questioned whether PGD would cause an alteration of telomere function in the airways. And they found actually that there is an inverse correlation between severity of PGD and the telomere length in the lung epithelium, suggesting again that the injury of CLAD can cause a degradation of the telomere in the lungs. And when they could perform an analysis to see if that was associated with more risk of CLAD, the patient that had shorter airway telomere definitely were in increased risk of developing CLAD at early stage compared to the others. So in conclusion, we have an increasing number of patients that are over the age of 70s, especially in the United States, related to the changes in lung disease. We are improving their survival, for sure, short-term survival. There is a large impact on quality of life. They definitely are living better. Shadows, increased mortality. We're still working on improving their mortality, and Dr. Pavliska is going to talk more what are the risks associated with that, and more to come on telomere length at both sides, lymphocytic and airways. That is very interesting, especially for the injury. And with that, I would like to thank you, everybody, for the attention.
Thank you very much for your excellent presentation. I would like now to introduce our last speaker, Dr. Elizabeth Pavlisko. She's an associate professor of pathology at Duke University Hospital, where she serves as division chief for pulmonary thoracic pathology, as well as director of the division of anatomic pathology and digital analytics laboratory. Her clinical and research interests focus on lung transplantation, pneumoconiosis, and mesothelioma. She currently serves as lung co-chair for the Banff Foundation for Allograft Pathology and is an active member of the ISHLT pathology professional community. Elizabeth, please.
Thank you so much, Gregor and Fiorella. Thank you to the organizers for the invitation to speak on elderly lung allograft recipients, lights and shadows for the pathologist. So from the perspective of the pathologist, let's take a look at what we might expect in the tissue. It's important to consider, as Lorenzo mentioned, that not everyone ages in the same way, and someone's chronological age might not be reflective of their biological age. And so while I might expect a less robust immune system in an elderly lung transplant recipient, leading to decreased rejection and perhaps an increased incidence of malignancy, infection, and CLAD, let's take a look at these one by one. We'll start with rejection. There are some older studies. This one is from the Toronto group, looking at their early experience with lung transplantation, that have shown that acute rejection at greater than 6 weeks post-transplant, as well as chronic rejection, were less frequent in older lung transplant recipients. However, this was 30 years ago, and changes in management have occurred over the last 30 years. If we look to 2011, there's a study from the Cleveland Clinic that was aimed at determining risk factors for acute rejection after lung transplant. And they showed that it was actually the age of the donor that had a statistically significant impact on the incidence of rejection. So a younger donor corresponding to an increased incidence of rejection, and the converse being the same, or also being true. More recently in 2020, there was data published from the CTOT 20 cohort. This cohort was from a multi-center prospective study of 5 North American transplant centers, and the overall aim of this was determining risk factors for CLAD. This particular manuscript coming out of that work looked at risk factors for acute rejection within the first year following lung transplantation. The data showed that there was no increased hazards for acute rejection based on age less than or greater than 65 years. It is well established that in the first months following transplantation that there is a bit of a flurry of acute rejection, which then tapers to a lower level. Here I'm showing you data that you also saw Dr. Zafiri show. This is from the University of Pittsburgh. And if I draw your attention to the upper right-hand graph, we see patients with normal telomeres. And this data is looking at the incidence of rejection in lung transplant recipients, specifically with IPF. And we see that the year 1 A-grade rejection score seems to be consistent across all age groups. However, if you draw your eyes to the bottom right-hand graph, in year 2, we see a trend towards decreased acute rejection in older lung transplant recipients. Interestingly, if you draw your attention now to the left-hand side of the screen, we see that the year 1 A score for patients with short telomeres has a more dramatic decrease in the incidence of rejection during year 1 as we move from younger to the older age groups. So while we would expect to see a decrease in severe acute rejection, likely due to immune senescence in the elderly, this has not been clearly shown in the literature in the first year following transplant outside the setting of short telomeres. Briefly, this data is from the 36 adult lung and heart-lung transplant report from 2019, and it looked at known causes of mortality in lung transplant recipients. And in the red box, you can see that as we move from the left side of your screen to right and the row of acute rejection, we see the incidence of death decreases as time post-transplant increases. Conversely, we see that there is an increase in mortality from malignancy as we move further past the 1-year time point. So now let's move into some of the shadows where the complications live. And we'll start by addressing malignancy and the incidence and mortality in the elderly population. So we know that lung cancer can occur following lung transplantation in there's sort of three main areas. It's cancer occurring in the native lungs. This may be incidental in a diseased lung, or this may be a purposeful transplant for known early stage disease. Cancer can also occur in the allograft, and that might be donor-derived or de novo. And then thirdly, you might see recurrence in a patient who is transplanted for known cancer. Let's take a quick look at cancer arising in the allograft. So Lee and colleagues reviewed data from the UNOS database from a period of 1993 towards onward to 2022, focusing on de novo malignancy after bilateral lung transplantation. From that study, we see that the incidence of lung cancer ranks fourth, with skin cancer of squamous origin, followed by basal cell origin, and then lymphoma being in the top three. If we look at age grouped by decade, we see that there is an increase in lung cancer for recipients in their 8th decade of life. And while lung cancer was the fourth most common malignancy, it appears to have the worst survival. Triplett and colleagues asked the question, what is the risk of lung cancer in lung transplant recipients in the United States? And they utilized data from the Transplant Cancer Match Study to compare the incidence of lung cancer amongst recipients to the general public. They found an almost 5 times higher risk of lung cancer in those transplanted versus the general public, and the risk was substantially higher in the native lung of single lung transplant recipients. Risk factors that they report include older age at the time of transplantation, lower educational level, history of smoking, longer time since transplant, and the highest incident was in patients with a history of COPD or IPF. The patient that was presented today had an incidentally discovered lung cancer. The reports of incidentally discovered lung cancer range from 0.5% to 2.9%, with adenocarcinoma being the most common histology, followed closely by squamous. Interestingly, there are some transplant centers who are purposefully transplanting patients with known early stage disease. And Spies and colleagues at Duke published a series of lung transplant recipients with incidentally discovered lung cancer, with a question in mind of, should we be transplanting these patients? Is the outcome comparable in patients with early stage disease to those that lack lung cancer? The data in this cohort includes patients transplanted after 2002, and many of these patients are over the age of 60. The authors reported outcomes of recipients with early stage disease to be comparable to patients without lung cancer. And so if we look at the chart here, you can see that the patients who had the largest tumor size, and then move your eyes towards the right-hand side of the screen, went on to have cancer progression as a cause of death. So the data does support an increased incidence of malignancy in elderly lung transplant recipients, and we can confidently include this in our list of shadows. Moving on to infection. Gutierrez and colleagues identified 42 patients transplanted prior to 1999. These recipients were greater than 60 years of age, and they compared them to a younger matched cohort. Their study shows increased mortality in the elderly post-transplant group in the early transplant period, defined as greater than or equal to 6 months, in comparison to the younger cohort. So we know that the immune system is less robust as we age, and that T-cell senescence is associated with an increased risk of infection in kidney transplant recipients. That was described by Pickering in 2022. We see that there is increased mortality due to infection that has been reported in older lung transplant recipients. However, in the literature to date, there's no clear link between numeric age or chronological age and risk of infection. There is a report out of Tampa by Hyman et al. That looked at overall major bacterial, fungal, and viral infections and showed that they were not statistically different between those greater or less than 65. All right, so we will move on to CLAD. So Faust and colleagues reported in 2017 that donor allograft telomere length impacts clade-free survival. More recent work by Greenland and colleagues has shown that short airway telomeres are associated with clade, and that increased PGD severity was associated with shorter airway epithelial telomere length, and that's shown in the image on the left-hand side of your screen with telomeres in red and the airway epithelial cells in blue. To date, there has been no clear link between numeric age of the recipient and the risk of clade. And so while we would expect maybe lower rates of rejection due to immunosenescence and in turn higher rates of malignancy infection, the increased malignancy is very clear and strong in the literature. However, while some early studies showed decreased episodes of mortality secondary to acute rejection, it's more difficult to confirm the link between age and decreased acute rejection in the 1-year time period. And then the same is going to hold true for infection. While there is some increase in mortality due to infection in older versus lung transplant recipients, recent reports have not shown a significant difference between age and the incidence of infection. I do lastly want to touch on telomeres and risk, because this is an evolving story that has captured a lot of interest. And interestingly, in the setting of short telomeres, we do see the literature supporting decreased incidence of severe rejection overall, even within 1 year, an increase in malignancy, infection, severity of PGD, as well as clade. And as I mentioned, there appears to be great interest in this area and the impact of both donor and recipient telomeres on lung transplant outcomes. And I expect more to come as this story unfolds. Thank you.
Thanks, Elizabeth. Thanks, Lorenzo, for really your great talks. A great overview about light and shadows in elderly recipients. In the meantime, some questions come from participants. I would like to start with Lorenzo with a short question, a comment. The patient developed a constrictive pericarditis soon after lung transplantation. Grace reported also the experience from Duke University. Is this a more frequent complication in elderly recipients, or which is the most frequent etiology of pericarditis?
Good question. It is a rare complication, and I think the two main in lung transplant and in cardiac thoracic surgery in general is a rare complication. If we look at lung transplant, I think Duke has an experience at PAM and presented the incidence 0.8, so 10 cases out of 1,200 lung transplantations. Those patients were male, all of them. They had IPF, and 8 and 2 had COPD. There were no, in those patients, there weren't anybody with connective tissue disease, so that is kind of unusual. If you look more in the general cardiac thoracic field, it's a little bit more common after CABG. That is usually the #1 cause of constrictive pericarditis, like after cardiac surgery. And there is a little bit, and pericarditis viral or idiopathic, and that is a little bit more common, about 8%, I think, in patients that have connective tissue disease. I think again, the combination of the two things, like a lung surgery and somebody with connective tissue disease, led to this outcome for our patient. But it's not extremely common, so it's very difficult to give you an etiology, a final etiology.
Okay, thank you. We have another question for the audience. We have from Anya Roden. Thank you to the speaker so much for the presentation. I was wondering about the telomeres measurement in airways. Is that already in clinical use or only in research currently? Also, I assume you need fresh material for that BAL.
Yeah, wonderful question. It's only on research right now. This is the first experience that was published, and it was only, I think, a very small number of patients. Also technically a little bit challenging from a pathological standpoint of view in terms of doing a telomere fish, measuring the ratio between cell and DAPI and telomere fish. So it's not an easy procedure and technique, but it seems to be pretty interesting. And I think, again, looking in the future, when if you assume the incidence of any injuries, any injuries to the lung, allograft can lead to more telomere dysfunction. That's something that we should probably start considering. Again, we kind of have that idea that respiratory virus infection can cause more rejection, PGDs associated with worse lung allograft survival. So I think that the idea is there. That was a first proof of concept, and I think it's very interesting. Not yet ready for clinical prime time.
But is it difficult to perform a telofish or molecular analysis this is a question I think for Elizabeth.
Thank you. Yes.
So I would say, is it difficult to perform FISH? No, yes and no. It depends on what you're dealing with. I would wonder, I'm not exactly sure from John's paper if he was using bronchial brushings or bronchial biopsies, but I think probably the rate limiting step is creating, getting the FISH probe and getting that FISH probe validated so that you know what the reg signal is tagging truly is, the end piece of that chromosome, the telomere. And so, yeah, can be slightly more challenging than some other studies.
Yeah, I have another question for you, Elizabeth, about lung cancer. We said the incidence in end-stage ILD has been reported with a wide range, but do you think there could be due also to different methods of sampling of the native lungs, and maybe we should have a different approach for different etiologies of the for the lung that led to the lung transplant?
Sure, great question, and a topic of great interest. I think one of the most important things when approaching a set of native lungs, we should always be considering the possibility of cancer in a set of lungs. And for us here, that's why we always take a bronchial vascular margin and sample, representative lymph nodes, is because you never know when you're going to run into cancer. 2 would be always looking at the radiographic imaging prior to grossing a set of native lungs. And then 3, just keeping your eyes peeled for subtleties. I think when we look at the wide range that's reported for the incidence of lung cancer incidentally discovered, it might be that it's the underlying cause of the patient's ILD that is, driving that increased risk. So, were they a smoker? I've seen some association between smoking and IPF, and we know that smoking, assists in eroding those telomeres. So was the patient a smoker? Do they have IPF? Are we possibly in a short telomere syndrome type patient? And then, if we're not, how robust is the remodeling? Is this a patient who is transplanted for interstitial lung disease, which I think about more peribronchiovascular remodeling of the airways and possibly more of an adenocarcinoma arising, in that area. So I think that sampling is, yes, very important, but that also we might need to consider the underlying cause of the patient's, what was the reason for transplant?
Great. Yeah, I have more than one question for Lorenzo. Lorenzo, in one of your first slides, you showed that single lung transplantation seems to go better in older recipients. Is it right?
Yeah. It seems to start to change, but I think the majority of older recipients receive a single lung transplant yet.
Do you have any reason why double lung could have so negative impact on the procedure?
Definitely it's a bigger procedure, larger, longer time in the operating room, longer time in there is longer time on the ventilator post-op, as been shown in some of these studies. So I think that increases a lot of risks for outcomes in terms of infections and early mobilizations. I think also doing a single per se, it's surgically wise, the operation being smaller in terms of also actually the area that needs access. So it's like an anterior thoracotomy Oftentimes, right now we're talking about smaller invasion, minimally invasive or shorter surgical incisions. So all those things, I think, have an impact.
And in the balance of different recipients factors that must be taken into consideration in elderly recipients, in your experience, what is the impact of donors' characteristic?
Yeah, good question. Given the amount, here in the United States, we are definitely increasing the numbers of these older patients. We have also looking in trying, I think there is a movement, or at least an idea, moral or ethical move from the community, try to use what we call less ideal in terms of age, especially donors. There were and there are increasing number of papers that look at using older donors, age donors for this transplantation. There are contrasting as very often in between North America and European data. There are a couple of papers from Leuven and Hanover that show that using donor with the age of 70, there was no difference in survival. However, a retrospective study here in the United States did not show the same. So there was a worse survival using 55 and older transplant. In all these experiences, the recipients were older as well. So there is that kind of, trying to use a little older patients or donors for older patients. That is something that is happening. I think, again, we're going to learn more, but the experience is a little contrasting, but it seems that it's fine, again, for the first 3-4 years. Then things might change.
Okay, I have another question, maybe for Elizabeth. Elderly recipients have lower rate, as you said, of moderate and severe acute cellular rejection. However, due to a more frequent telomeropathy, they are at high risk of clade. Do you know the most plausible mechanism, maybe more frequent infections or something else? What do you think?
So it's sort of an interesting conundrum to be in, because we do associate acute rejection as one of those high-risk pathologies for clade. And so I think in that situation, you have to look at what else could be injuring the allograft. And so are there things like acute lung injury, organizing pneumonia from some cause? Could that be, antibody-mediated rejection? Could that be infection that's driving injury? And is that injury in turn what is creating the stress to provoke clade in that recipient? So it's a curious story.
Elizabeth, just a curiosity from your experience. In your center, which histotype is more frequent in this unexpected lung cancer?
Very interesting. Yes, so we saw adenocarcinoma as being slightly more common than squamous cell carcinoma. Interestingly, there were a fair number of carcinoid tumors. They were also present, but adenocarcinoma was the most common histologic type, and most were of low stage.
Thank you.
I don't know if Grace is back with us or for a question, or maybe someone else can answer about the constrictive pericarditis. If we go back to that, because the patient in this case had rheumatoid arthritis related ILD, so we don't know if maybe the patient had polycerositis or anything, or other things that are ERA related that could possibly explain the constrictive pericarditis. But if Grace is not here, maybe she's the only one who knows the patient. So
No, I think I can answer. Like, I actually was still at Duke at the time. It was one of my patients. We saw the patient together. In the pre-transplant evaluation, the patient had really well controlled connective tissue disease. It was on Humira and Henbrel, so it was on immune modulatory medication, but had no symptoms whatsoever of external, like other than lung involvement of serositis or arthritis or things like that. So it was well controlled. Again, there is the connection with serositis and the development of the constrictive pericarditis. I don't think it seems to be kind of part of the risk factors. How much played a role is a little bit difficult to say. Obviously, also at the time of transplant, he was not taking any of his immunomodulatory medication. He received basiliximab. So is that possible that might have a flare and that presented as a pericarditis because it was also kind of instrumented? That's possible.
Thank you.
No other question. I think we are on time to close. And before closing the webinar, let me thank all those who contributed to the success of this webinar. I thank all the speakers really for their excellent contribution. All of you for participants and registering to this webinar. The ISHLT staff, in particular Juliet Osa Zem-Wind, for assisting us. And I look forward to meeting you all at the ISHLT annual meeting in Prague.